Assalamu alaikum. Can you hear me?
Yes, doctor, we can hear you.
So are we going live yet?
Dr. Omar and Dr. Abdullah are here.
Okay. So just give me a few
السلام
second
عليكم.
alert to go ahead. سلام هلا عمر كيف حالك؟ يعطيك
حياك
العافية.
الله يا على فيك حياك السلام.
Just let us know when are we going to start the meeting.
Recording in progress.
طيب, I will go ahead and get started with the meeting. بسم الله الرحمن الرحيم. Assalamu alaikum. Good evening, everyone. Thank you for joining us to our fifth refer program, sponsored by Johnson & Johnson. We appreciate the unlimited support that they are giving to treating and diagnosing pulmonary hypertension in Saudi Arabia and globally. So much appreciation to their sponsor and support to this scientific activity. As you might be familiar with the refer program, this is a program that's intended to spread awareness about pulmonary hypertension into different specialties, from primary care to even the subspecialist pulmonary and cardiology specialties. We have a comprehensive program tonight, and hopefully it will be straightforward and relevant to your practice. And as the name indicates, the idea here is to really some of the cases, even the things that we see in our subspecialty centers and the clinics, and at the same time open the opportunity for networking with subspecialized folks, people who treat a specific disease. And we are here for you and for the patients and for anybody who requires any like question, any referral, any like obstacle he's running with any of his patients. So you are more than welcome to directly get in touch with any of us. And we are working at King Fahd Medical City Cluster 2, if you wish. And we are really happy to accommodate all your needs and all your patients. King Fahd Medical City Pulmonary Hypertension Center is one of the mature and advanced ones in the kingdom. We have enough number of experts in the field, from cardiology, pulmonary, pediatric, and critical care as well. And we are having almost access to every treatment modality for the disease. So we're going to go ahead and get started without any further ado. I will go ahead and give you a little bit brief about the pathobiology and the classification of the disease, trying to get the picture clear in the minds of everybody, and hopefully you will find it useful to your practice. This is a picture of the pulmonary artery. As you see, it is very thin, it's very nice, surrounded by a healthy lung. And this is how it is created, and this is how it should be, so that the cardiac output from the heart will be accommodated into these small, thin layers of pulmonary vessels, so that the gas exchange will take place in the lung, where oxygen will be picked up and carbon dioxide will be released into the atmosphere. And this is the essence of having a very good a gas exchange system that was created by God. As you can see, the pulmonary circulation is considered a low pressure circulation, unlike the systemic circulation, where on the left hand side you see the pressures in the aorta and in the large arteries. As things go from systemic to pulmonary, are really extremely low. And this is again for some reasons that you really don't have a lot of resistance. So again, resistance is low, they are different, the pressures are high because the capillaries and the alveoli are closed. But once the newborn, the baby, is taking the first breath, everything gets opened and all the blood will be shuffled from the systemic circulation. The PDA will be closed and the pulmonary circulation starts accommodating the cardiac output. The capillaries will open, the the alveoli are open, and normal gas exchange starts taking place. So the most important breath that we take is that first breath, where the pressures will be dropped and the function of the lung will be assumed. The pulmonary hypertension, as you can imagine, as simple as it can be, is elevation in the pressure in the pulmonary circulation. So normally the pressure is low. If the pressure becomes above 20, normally it's up to 19 as the upper limit of the normal. If it's beyond the 20, that means the pressure is high. And it is usually associated with increase in the pulmonary vascular resistance to more than 2 Wood's unit. And normally it's around 1 or around 1. This is the normal. So if it's more than double, that means that we are having a resistance issue in the pulmonary circulation. And then we can easily say that there is a pulmonary hypertension. But again, the disease is a little bit more complicated, and we will go through the journey of the description, discovery, and the classification of the disease. History of the disease is relatively recent. It was described in some case reports based on some pathological findings back in the 1891. I was told that it was about 30 years before somebody did hint to it. But again, at that time, we did not know much information. They noticed that the pulmonary vessels are sclerosed, so they called it a disease that leads to heart failure with association of pulmonary vascular sclerosis. And this is the first description of it. Now, through the years, there were some collection of cases, mainly in the US, where people are working and trying to improve or create the right heart catheterization system. Dr. Driddale and his team, they were working on collecting some cases, and they managed to really start the hemodynamic definition of the right side of the heart. They are the ones who really did the first right heart cath, and they described the cases of pulmonary hypertension from a clinical and from hemodynamic perspective. They even, in case report 3 cases, they managed to publish their hemodynamic profile. And as you can see, the pressures are significantly higher than what you would imagine in patients who are considered normal or even having left heart disease. They even published the autopsy results of their heart, where the right side is severely hypertrophied, and there is definite pathology there. And of course, that's where the description came from, the sclerosis of the vessels and the plexiform lesions that were noticed back then in the 40s and 30s, and then finally the publication was in 1954. Then they collected a bunch of cases. There are 39 cases. They did it as a case series, and they published their report. And from their clinical experience, they did have a couple of comments that were probably bothersome at the time, and they continue to be. Primary pulmonary hypertension, at that time, the terminology has changed significantly, but they called it the primary. It runs a malignant course characterized by right heart failure, not infrequently terminating in a sudden death. So they were describing the clinical course of these patients being significant, severe, and fatal at large. And also, they were promoting their findings in the hemodynamics, that you should not just wait until the patient by default dies from the disease or present in a very advanced way. There are means that you can really diagnose them through your cardiopulmonary laboratory, meaning right heart cath and proper evaluation for them. That was in the 50s, and of course, the interest was limited to some of the experienced centers, all the way down to the the 70s, where there were a little bit of an outbreak of pulmonary hypertension in Europe, mainly Spain. They noticed that there is larger number of pulmonary hypertension cases are being surfaced. So the WHO had held a first meeting. It's called World Meeting on Pulmonary Hypertension, just to address the issue. No information back then, and they decided to meet periodically to see what is the result of people interested in the field and the findings at that time. There's no known, but treatment at that time. Interested people are extremely limited in the globe, and the disease was considered really rare. Some of our senior colleagues, they remember going to medical school saying, this disease is bad, just try not to get it, or hope that your patient does not get pulmonary hypertension. All the way to 1996, where the first treatment became available in a very, very interesting study that showed that there is benefit, and the treatment was continuous intravenous infusion of prostacyclin. Then there will be meetings periodically. 98, every 5 years, there has been World Symposia on Pulmonary Hypertension meeting. The last one was just around the corner, like in June, 1st of July of this year, and it was the 7th World Symposium of Pulmonary Hypertension, where experts gather, review the evidence, and try to come up with guidelines. They have been doing this since 98, every 5 years. Now, they initially grouped the disease into classification, not based on an anatomy or anything. They noticed a clinical presentation, pathological findings, hemodynamic profile, and the treatment strategy. So the classification of the disease has taken very early grouping into 5 groups, as you can see them, and this is from 1998. The groups has been maintained. They called the primary pulmonary hypertension. The name has changed, but this is the disease that we're interested in. They noticed that there is pulmonary hypertension that comes from the left heart. There is pulmonary hypertension that comes from the lung diseases itself. There is pulmonary hypertension that comes from pulmonary emboli and some occlusion of the pulmonary circulation. And there's a group of patients who have pulmonary hypertension that are not very well characterized. They do not fit the full profile of pulmonary hypertension. So they classify them into a unique group that is like a group 5, if you wish, and miscellaneous, a group where everything that does not fit the profile of the other 4, they put it in there. Now, this is published in 22, end of 22. This is the most recent guidelines on the pulmonary hypertension and the classification. They call the group 1 is pulmonary arterial hypertension. As you can tell, this disease is a very heterogeneous. There is an idiopathic form of the disease that can be vasoreactive or non-vasoreactive. There is a heritable form. There is forms that are associated with drugs and toxins, and a lot of diseases that we in internal medicine in general and medical specialties in particular, they do see them, whether you are a connective tissue disease doctor, you are an infectious disease doctor, liver doctor, heart physician, you tend to see cases that are somehow associated with the pulmonary hypertension. So the pulmonary hypertension results somehow from having the comorbid connective tissue disease, HIV, or congenital heart disease. And there is some, of course, is a unique feature disease called PVOD, pulmonary veno-occlusive disease. This is a very unique form of pulmonary hypertension. I'll have a slide or 2 about it later on, but it fits the profile of the pulmonary arterial hypertension, precapillary, and of course, in the pediatric age group, as I described earlier, the first breath where the alveoli will open, the resistance will go down. Some kids, they just fail to bring their pulmonary vascular resistance to normal, and they persistently continue to have elevation in the resistance and the pressure in the pulmonary circulation. So the group 1 is the classical group. This is the PAH that we are talking about, and we'll continue to talk about all through the presentation with my different colleagues when we talk about the diagnosis and the management strategies. But the other groups are worth understanding that they do come from left heart disease, and classically we always say the most common cause of right heart failure is left heart failure. So this is a very common group of people who have a left heart disease, and somehow the pressures inside the left chamber increase to the point where it will be reflected on the right side. And we do see a lot of them in the clinical practice. So the probability of you, with whichever specialty you are in, to see a patient with pulmonary hypertension due to heart disease is significantly high. And this is one of the things that we have to rule out early on so that we put ourselves in the right track of diagnosing and treating the disease. course, if you are a pulmonologist or you tend to see a lot of people with significant lung disease, they tend to have elevation in the pulmonary pressure because of, of the nature of their disease, whether it is COPD and destruction of the alveoli, or interstitial lung disease where there will be fibrosis, and some severe hypoxic conditions, hypoventilation conditions as well can lead to the disease. Now, group 4 is a unique group where recurrent pulmonary emboli do happen. I'm sure whatever specialty you are in, medicine, surgery, cardiology, you tend to see these patients, whether you are called to see them because of their comorbidities, or you are the primary treating physician in the emergency room, in the intensive care unit, or in some of the primary care clinics. It's a common disease that affects our patients. Small group of these patients tend to continue to have elevation in the pulmonary pressure after these emboli, and it's a unique group of patients that have a unique treatment as well. Our focus tonight is mainly on the pulmonary arterial hypertension group, but it's worth mentioning and knowing about these because they are common. And as I mentioned earlier, group 5 is the miscellaneous, some systemic disorders, some metabolic disorders. Renal failure patients not uncommonly have elevation in the pressure due to multifactorial reasons. Fibrosing mediastinitis is another common one that we tend to see in our specialty clinics as well. Hematological disorders are extremely common, whether the disease itself, where the hemoglobinopathy, sicklers, thalassemia, and sometimes the treatment related to the hematological malignancies can lead to pulmonary hypertension. So these are the classifications that are well accepted, very well mature. There's a lot of data about every single one of them, and hopefully I managed to just at least clarify some of these cases for you. So the more common is more common. This is just a summary slide that when we talk about pulmonary arterial hypertension, we are talking about a rare disease that affects, with all the associations, no more than 25 per million individuals. The very common ones are the heart disease and the lung disease. They are considered prevalent in our society. And if you want to guess, about 10% of older people, probably they do have pulmonary hypertension due to these other common diseases they have, whether the left heart or the lung disease. CTIF is again considered a rare disease. It's probably as common as pulmonary arterial hypertension, and the other ones are considered rare. Everyone and every now and then we see a case of them. So the definition of the disease, as you noticed, we talked about a lot of systems, we talked about a lot of classification. So we are not talking about a disease. We are talking about a hemodynamic stage. People who have different diseases, if they share a hemodynamic profile, they fit the classification of pulmonary hypertension. The pulmonary hypertension, as simple as it is, any pressure above 20 is PH, because normally it should be below that. The reasons for this to be in group 1, we can call it precapillary if you wish, pulmonary arterial hypertension. There is other conditions that have to be associated with it, which is low filling pressures in the heart, i.e. there is no left heart disease, since it's the very common to be associated with left heart disease, elevation in the pressure, and the resistance has to be elevated as well, because if you increase the flow into the pulmonary circulation, the pressure can go up, but the resistance will not go up because it will be normal. The vessels themselves are healthy, but the pressure is high because of the flooding of the circulation with volume. Isolated post-capillary, meaning that the patient's having a pure left heart disease, where the pressure elevation in the left heart does correlate nicely with the pressure increase in the right side. So this is isolated. Sometimes, and not uncommonly, especially in our subspecialty centers, we see cases where maybe the long-standing process of having heart failure affected the blood vessels themselves, where the picture can be a little bit confusing, where there are increase in the PVR and increase in the wedge and increase in the pressure. So this is, again, a unique case that requires some specialty, maybe some research, and caution when we tend to treat them with the available medications. And the idea is these are not to be treated with the classical way we treat them. There's a new entity called exercise pH. If all of us now start exercising, the cardiac output will go up. The pulmonary circulation, if it's healthy, it will accommodate that without elevation in the pressure up to a limit. Now, if this limit is exceeded, where you increase by 3 millimeter by 1 liter increase in the cardiac output, the interaction between the flow and the cardiac output and the resistance in the pulmonary circulation might be abnormal, and they called it exercise pH. There is not much data about the treatment of this disease and whether intervention earlier might have a benefit, at least at this point. But definitely, we do know that it does influence our exercise capacity. It might influence our ability to perform a lot of work. So this is just a simple diagram showing the pulmonary circulation, when we say pre-capillary, the pathology is before the capillary level, and when we say post-capillary, that means it's in the left atrium and beyond the capillaries, and then sometimes it might be combined, similar to what happens with pulmonary emboli. This is a patient of mine who have severe pulmonary hypertension, and this is their autopsy. Unfortunately, the patient died, and this is the blood vessel that she had in her lungs. So as you see, as compared to the initial picture I showed you, the blood vessel is obliterated with layers of cells, fibrotic material, and you can imagine the cardiac output, if all the blood vessels are like this, will not be accommodated. The pressure has to go up and the resistance has to go up. And of course, the disease will present itself in different clinical format. This is another patient where a patient did not die. Biopsy was taken for another reason, and it showed that their pulmonary artery is really infiltrated. This small slit in the middle of the slide is what is allowing the blood to go through, and the patient was presenting with symptoms related to basically heart failure. Pulmonary hypertension or pulmonary arterial hypertension is not a vasoconstrictive disease similar to systemic hypertension. The blood vessel, as you showed in the slides, there will be changes that are pathological. The artery itself will be hypertrophied, infiltrated with cells, fibrosed. Even the outside layers, the adventitia of the blood vessel will be abnormal. So this is not a tone. Now, if we get angry, if we get excited, our blood pressure might change as a reaction to reasons to increase the tone. In pulmonary hypertension, the condition is not the same. There are proliferative process that is associated with inflammation, proliferation, cellular infiltration, and of course, this does contribute to the progressive nature of the disease. It's not as simple as giving a pill, controlling the blood pressure, and life will be great. And as the time passes by, people will tend to be maybe early on asymptomatic, then they will start having mild symptoms that can be interpreted by so many other diseases. The presentation is so non-specific. You are a primary care physician, the patient might come with a little bit of shortness of breath, exercise limitation, unable to climb the stairs, unable to keep up with the peers at the mall or in the sports, and then eventually the patient will continue to progress until they sometimes comes dead in the emergency room or in a very advanced clinical picture of right heart failure, where they are edematous, they have ascites, and they are barely able to really maintain blood pressure and maintain oxygenation. So it's all the spectrum of the disease when they come to you. And like I said, this is a very non-specific, and you have to keep some index of suspicion whenever the clinical picture, the intervention that you did, whatever it is, does not fit the profile of response. The patient did not do better. Think it twice, and let's see what else could it be, and consider pulmonary hypertension in your differential diagnosis. Dyspnea is the most common. I think I have a little summary slide for this. Depends on how early or late in the disease you are, and of course some other association with the dyspnea might happen. Shortness of breath or hoarseness of voice. I have one case that presents with what's called Ortner syndrome, with the dilatation of the pulmonary artery. It affects the recurrent laryngeal nerve, where their voice will change. Hemoptysis is somewhat rare, but it does happen. Palpitations, a little bit of chest pain, sometimes they can present with these symptoms, but all of them are non-specific. And if you go ahead and examine the patient, probably at the time of the boards, all our trainees are good in knowing that when you put the stethoscope, you will hear a little bit loud P2, sometimes a splitting of S2, sometimes you might hear a murmur of whether it's regurgitant, sometimes you might see and hear features of the underlying cause of the pulmonary hypertension, but in general, these are not unique to the pulmonary hypertension itself. Yet, you have to be aware, it depends on the level of presentation the patient is. Nobody can miss a patient in the emergency room who is in shock because of right-sided failure. But again, sometimes early features might be completely normal. And you remember the exercise-induced pH that I mentioned. Sometimes you really have to be in stressful conditions in order for the symptoms and the signs to be present clinically. The classification of the heart failure, you must be familiar with it, between class 1, 2, and 3, and 4. It depends on how much the patient is able to do or not able to do because of their disease. And we follow the same classification when we come into functional class assessment of our patients. Some patients might be very well, where they are not symptomatic unless they are really exerting themselves to the point where sometimes they are really bedridden or wheelchair ridden. They cannot do anything without having limitations in their exercise capacity. So the question is, why does this disease happen? And this is a question sometimes our patients ask it, why me? And of course, in the past 30 years or so, a lot of research has been done into this area and lots of progress has been made truly. And I mentioned the first treatment was available in 96. Now we have about 15 different treatments, different pathways. Recently, there was a new pathway of intervention that was discovered, and a medication just became approved by the authorities. It's not available yet in our country to treat our patients, but again, things are moving in the right direction, and things are really progressing at the scientific level. So it's an interesting disease to see the science unraveling in front of our eyes, from no treatment into different modalities of treatment, and now we're talking into even advancing the management to the point where we can influence the outcome and the mortality. PMBR2 is a genetically affected receptor where it is responsible for programmed cell death. Some abnormality in this system might be congenital or hereditary. Some of it might be because of some mutations, but definitely it influences the ability of the vessel to really handle the cells inside or lining the vessel. So when you lose your ability to die, or you lose your ability to really apoptose, this will lead to hyperproliferation of the cells and obliteration of the vessel, as I showed you before, and you don't have to worry about this. Another hereditary disease that is very well described now is the PVOD. I mentioned that to you. PVOD is of a disease that is presenting similar to pulmonary hypertension, but in reality, the genetically determined disease in the young, it really leads to venular and capillary diseases where there will be changes similar to the grapes. If you look into the pathology, the consequences clinically are the same. The hemodynamics, a lot of time, they do behave the same. But when you treat them with pulmonary vasodilator therapy, they have pulmonary edema, they flood their system, and they might not be a candidate for this therapy. Best option is to give them a lung transplant, and this probably will cure them. Some recurrence has been described. But this is another form of the pulmonary hypertension that is, again, very well characterized. It has a genetic makeup into it. Some of the secondary forms of pulmonary veno-occlusive disease that we tend to see, Down syndrome is commonly associated with it. A lot of connective tissue disease patients might be affected with it. Some chemotherapy might really lead into this state. So again, in idiopathic form, it is hereditary, and it affects youngsters in their 13, 14 teenage years. And we've seen a few cases, and some of them has already been transplanted. This is just the description of the gene. This is a French study. They have 13 families where they described and characterized the gene that is associated with them. The disease is unique, as I said, in its treatment, but clinically, they do have digital clubbing. We usually don't see clubbing in PH patients, and they do have pleural effusion because of the affection of their pleural capillaries. And of course, there will be some crackles that are associated with the volume overload or the edema that you see. On the CT scan, you might see some lymph nodes enlargement and some engorgement of their lymphatics. Another mechanism of the disease happening is the quasi-malignancy disease, where I mentioned sometimes the cells, they just tend not to die. They continue to proliferate. They continue to recruit stem cells from the bone marrow. And of course, this will lead to, similar to the pathology of cancer, where there will be more and more uncontrolled proliferation. And this is just one of the mechanisms. Probably it is somewhat true as people now talk more about the stem cells and their role in the different diseases. And sometimes probably in the future, we will see some treatment that's affecting the stem cells themselves. Some of the non-FDA approved medications that was in South America, basically, patients are desperate. They tend to go, they call it stem cell therapy for pulmonary hypertension. The data is still not strong to start even talking about it in a clinical level. They noticed, again, from the discoveries and the studies that were done on these patients early on, that some molecules that are really pathological, they can influence the development of the disease. Endothelin is one of them. Endothelin is a bad molecule that is like toxic, maybe tumorogenic. It really leads to increase in the pulmonary vascular resistance, and like endothelin is bad. Notice that in patients with pulmonary hypertension, the level of endothelin is high, and their representation in the receptors inside the pulmonary circulation is high in patients with pulmonary hypertension. So again, that was one of the ways or ideas to start treating the disease by approaching the endothelin receptor blockade as a main mechanism of treating the disease. You will hear about treatment later on. Nitric oxide pathway and abnormality in the nitric oxide pathway might be associated with pulmonary hypertension. There are some genetically determined NO synthase deficiency in pulmonary hypertension in animals and even in humans, and this will lead to really uncontrolled presence of toxic radicals that are resulting from the NO, and of course that will contribute to the development of pH. So that's another way to treating the disease, by approaching the nitric oxide pathway, trying to prevent this from happening and regulating the availability of nitric oxide. Nitric oxide is a good molecule. We need it to bronchodilate, to vasodilate, to improve the the cellular health, if you wish, the cardiovascular system as a whole, in the left heart, in the right heart, in the blood vessels. So again, making available of the NO is a good thing that has a lot of implications on the clinical grounds. Of course, when you do have a problem with hyperdynamic circulation, this sometimes might lead to shearing forces. The blood vessel itself does not like the increase in the flow, and it might lead to reactionary development of pulmonary hypertension. Some medications might be associated. I mentioned that, and this, classically amphetamines. We have seen not good number of patients who they do have pulmonary hypertension, and the oncology ward, I mentioned some of the medications, the dasatinib, for example, they treat their CML patients, might drugs. These are not available anymore. They were pulled from the market many years ago. But that was how it was started from this class, and then the observation of the development of pulmonary hypertension was made. Of course, some of the other agents are not very well described and characterized, but medications can be associated with pulmonary hypertension as well. Connective tissue disease, we mentioned, again, going quickly through the classification, is not uncommon. About a quarter of the patients who are seen in the pulmonary hypertension clinics do belong to this category, specifically scleroderma, some SLE, and a little bit scattered of all the other mixed connective tissue diseases, common one, rheumatoid arthritis, Sjogren, and all of that. And the development of pulmonary hypertension in scleroderma is really bad. These patients tend to have very severe mortality disadvantage once they develop pulmonary hypertension. The disease is bad by itself. Association with pulmonary disease, fibrosis in these patients. Liver disease, like somewhat uncommonly, up to 5% of patients who have end-stage liver disease with evidence of portal hypertension, they develop pulmonary hypertension. It's called portal pulmonary hypertension. Unfortunately, if they develop this, they are not candidate for liver transplant, and this is something that is recommended to screen these patients before you even transplant them. HIV, uncommonly associated with the disease. Now, we don't have a lot of HIV patient pool in our region. That's a good thing. But people where they have larger number of HIV, it looks like PH is becoming prevalent because they live longer with the good medications, the antiretrovirals, and the management of when they get sick with immune suppression, they tend to have the disease in a more classical way, and they tend to die from pulmonary hypertension, as was told by some colleagues. Remember, right lung or lung diseases, left heart diseases are common. This is a global study looking into the distribution of the causes of pulmonary hypertension in general, and across the board, the left heart disease is the commonest. Next to it is the lung disease, and pulmonary arterial hypertension continues to play a smaller role in the big pool of pulmonary hypertension patients. So again, it's a rare disease, but it is so important, and you will hear a little bit more about it, about the outcome of these patients later on. We talked about the lung disease. Some inflammation goes on, some destruction of the lung that can contribute to the development of pulmonary hypertension. This is the group 4 I mentioned earlier, where recurrent emboli will lead to occlusion of the pulmonary circulation. And as you can imagine, when the blood is not going there, the resistance will go there. The clinical picture will be present in the patient, but inside the blood vessels, there will be occlusion of different size vessels, and the treatment for this is surgical usually. Yes, we have medications. The patients tend to stabilize and do better symptom-wise, but ultimately they will probably benefit from having the clots taken out. And we're not talking about clots, we're talking about fibrotic material that's very dense, very thick, that when it's out, the patients tend to do better than just continuing to have this inside their lung. So this is a summary slide that we can imagine pulmonary hypertension, a patient who have some genetic makeup, some predisposing factor. This individual has been exposed to a risk factor that is commonly leading to some vascular injury, and the blood, the body has reacted to this vascular injury in a pathological way, where there will be more proliferation of the cells, more inflammation, more cytokine recruitment, and eventually the cells will get out of control and continue to grow, where the patient will present with the clinical presentation. To have pulmonary hypertension is a bad disease. It's really, the outcome is significantly worse than not having it. Affects young people. In general, our average in Saudi Arabia is between in the 30s, early 40s, probably. This is the majority of the cases we see. In the North America, probably 50 is the age. Some European countries, they even exceed that to 60, 65. But again, this is a young individual who's just starting their life, and you tell them you have a disease, the probability of survival is about 2/3 in 3 years, maybe less than half in 5 years. This is continued to be a problem in even with advancement of therapies. So that's why the fight has to continue. Spreading the awareness has to continue, because the story is not over yet. We tend to lose some of these patients from not being picked up early on. They present late, and sometimes they cannot access the proper centers where they can provide them with therapy. Different diseases or subgroups of PAH, they have a little bit different prognosis. The best ones are congenital heart disease, but all of them in general, they tend to do worse than not having the disease itself. This is one of the most recent data. The earlier they present, the better off they are because of the intervention. If they present at functional class 4, that means their probability of survival becomes extremely limited to less than a third by 5 years of their existence. This is all data, but it looks like it continues to be the case. We do tend to diagnose the disease late, and the diagnosis is mainly, or the first encounter will be the primary care physician, internal medicine doctors, emergency room sometimes, maybe subspecialist who is not primarily involved in the process. They can hear that this patient is having some symptoms that's probably away from their specialty. They tend to have longer time before they get referred to the right clinic, to the right place, to the right people who can diagnose them, initiate therapy early, and influence their overall journey of the disease. This is from Australia. The numbers are somewhat about 10 years ago, but the numbers are really bad. The average patient tend to see 6 or 7 specialists, and before they get the diagnosis, it takes an average about 4+ years before the diagnosis is firmly established. So I hope that this has given you the reasons why we are doing this, that the disease is bad enough that we tend to sometimes miss the cases. We do look for them earlier if possible. We also wanted to let people know that the available resources are there, and the Ministry of Health and Kingdom is one of the advanced countries in the diagnosis and management of pulmonary hypertension. We have very well established groups who have been working on this for many years now. We have an association that is very well recognized internationally, that we have an international conference that we do every year, and we do participate in international conferences. We are now doing clinical trials in our centers. King Fahd Medical City is participating in 3 ongoing clinical trials that is in multi-center, multinational trials in pulmonary hypertension. Just show you a case. This is a nurse that is working in the emergency room. She was on the shift that day. She's in her early 30s. I was on call, walking by the emergency room. Somebody gave me this ECG. The ECG looked really bad. It's more of a right-sided ECG than anything else. There is a strain pattern, and the young human being was on her shift. So she did have some symptoms, not bad enough to put her at home, but it was significant where she did wanted to do some workup while she was in the emergency room. This was her X-ray, and of course, this is a very abnormal X-ray in terms of the cardiac size. Turned out that she came with the same presentation a couple of years before this one, where her X-ray was passed as normal. This is not a normal X-ray, and this is her employment X-ray about 4 or 5 years before that. The first X-ray I showed you, that was missed again, and it was led to being normal. The patient did have some symptoms, non-specific to the point where, and of course, we are bad in the as patients. Healthcare workers are bad as patients, because we tend to at least to try to avoid coming to the doctor or justifying why are we having the symptoms. Again, what has happened has happened. Her echocardiogram showed significant pulmonary hypertension. You will hear all about the echo in the next lecture. And of course, this was associated with dilatation of the pulmonary circulation. There were no PEs, alhamdulillah. Her PEs are, and we did the right heart cath, which is the ultimate diagnostic test, and she did have severely elevated pulmonary artery pressure into the 62 level. And we said the 20 and above is considered abnormal. Her mean pulmonary artery pressure was 62. She's still alive. She's on triple therapy. Hopefully she will continue to do well, similar to the other patients that we wish them the best. I will stop here and I will leave the room to my colleague, Dr. Abdullah, who will be talking about the diagnostic workup for you. Thank you so much. Dr. Abdullah is an interventional cardiologist. He's a pulmonary hypertension expert at King Fahd Medical City, and he has special, not only training and interest, and he's actively seeing patients with PH. Dr. Abdullah?
Assalamu alaikum. Thank you very much, Dr. Hussam. Let me just share my slides. You can see my slides now?
Yes.
Okay, so my task will be a little bit easier after the nice talk and foundation laid by Dr. Hussam. And I'll be touching on how we detect this rare disease, and if we thought about it, what's the diagnostic workup of pulmonary hypertension. So the issue of detection is basically you're trying to detect something or screening in asymptomatic patients. And as Dr. Hussam mentioned, there is worldwide problem with pulmonary hypertension in that there is usually a delay in diagnosis. And on average, this delay, even in the best care, in the best case scenarios and countries with advanced healthcare, the delay is about 2 years from the symptom onset until the diagnosis is made. The problem is PAH is a silent disease initially until later in the stage of the disease where significant remodeling and obliteration of small vessels has occurred, and the chances of reversing that process is somewhat limited. So as Dr. Hussam mentioned, the symptoms are usually very mild when the disease is in the early stages and usually are non-specific. So things like exertional dyspnea, this is a very common symptoms, and you can see it with a lot of different conditions. Syncope, again, especially in the young, can be sometimes labeled as vasovagal or ignored altogether. Angina can occur, and limitation of exercise capacity is a symptom that has a lot of differential diagnosis, and PH is usually not one of the top differentials when it comes to that. So usually patients are labeled with either asthma, bronchial asthma, or heart failure, or just lack of fitness, or sometimes even depression before pulmonary hypertension is being entertained. And the problem is the more advanced symptoms the patient has, the worse the prognosis is. So that's really something we have to pay attention to. So the first take-home message is that PAH, pulmonary arterial hypertension, is rarely suspected until it has reached an advanced stage, and at that time, the prognosis is really considered poor. Most of the PH registries show that around 70% of patients, when they present at NYHA class 3 and 4, which is really late in the course of the illness. The hope is if we detected the disease early, we can at least partially reverse the process. So as we can see here, if we do an early intervention and we detect the disease early and we start treatment early, we can prevent this line from going down and down and down, causing further reduction in functional capacity and reaching to the state of irreversible disease. So that's the hope, is we can target our patients early on and then start them on treatment early on so they don't go to the bad state of the disease. So how do we do that? We do it by increased awareness of the illness, of the disease, of the signs and symptoms, by trying to detect early and screening high-risk patients. And of course, once we diagnose the condition, we should treat early and also treat to target. And thereby, hopefully, we can achieve improvement on long-term outcome. So in general, the word screening means that we do a systematic testing of an asymptomatic individual at high risk of a certain condition. So the screening method should be something that is non-invasive, something that is reproducible, i.e. accurate, and it has a high negative predictive value. And there's an intervention that can be done once the disease of interest is diagnosed, and it has to be cost effective. So those are the conditions that should be there when we are thinking of screening of pulmonary hypertension. So in PH, for example, we can do screening in high-risk individuals by the following tests. So physical exam by itself is considered a screening because you're trying to look for something in a high-risk individual. So if you hear a loud S2 or a murmur of TR, then that should trigger additional investigations. Echocardiogram is also another screening modality, and ECG can help you by finding some changes that tells that there is a right side or right chamber enlargement. PFT, DLCO, and also circulating biomarkers, the BNPs, are also tools that we can utilize to help with screening. So the challenge of screening is that PAH is a very rare disease, and systematic screening at population level is not practical, nor it is a cost effective. So the prevalence and the associated condition is only known when gold standard test is applied, which is a right heart cath. So when it comes to screening, there is basically limited evidence to guide the screening strategies for PAH. It is not very clear which population should be screened and how often. It is not very clear which tools should be used, and can we combine different tools to better predict the risk of PAH. And finally, how to calibrate the screening tools. So those are some of the challenges of screening. Which patient population should we screen for PAH? I think certainly patients with connective tissue disease, be it systemic sclerosis or SLE, very rarely rheumatoid arthritis, but mixed connective tissue disease, those patients, they deserve to be screened. Anyone with a family history of pulmonary hypertension should be screened. Patients with underlying congenital heart disease, HIV infection, like Dr. Hassan mentioned, portal hypertension, anyone with history of drug use or any of the toxins that are known to cause PH. Those patients with history of recurrent PEs, and finally, patients with sickle cell disease, which is quite prevalent in the kingdom. So once we screen and we have enough triggers to go to the diagnostic workup, then that should follow the following algorithm. So echocardiogram should be the first test of choice to help you go further in the algorithm of pulmonary hypertension. So let's talk about basics of echo. So basically, the echocardiogram utilizes three different aspects. It uses one-dimensional imaging, and it uses two-dimensional imaging, the moving pictures that we see, and then finally it uses something called color Doppler. Let's just go over each one of these. So basically, the basics of ultrasound is that we have a probe that transmit ultrasound beams into the body, and then these ultrasound beams gets reflected, scattered, and attenuated, and they get reflected on different tissues. And the signal that is reflected is read by the ultrasound machine and interpreted in a color scale, either white, black, or something in between, based on the intensity of the reflection. So basically, if you have a beam that is sent by the probe and then gets reflected by a bone, it will be read as white. If there is no reflection, then usually that's blood or air. So it reflected as black. So that's how we know what's going on. So basically, this is a one-dimensional image, and we can see that there is only time motion that displays the ultrasound wave along a chosen ultrasound line. And then this is not quite used nowadays, except in like certain aspects. This is an example of a utilization or one usage of one-dimensional imaging. We're trying to measure something called TAPSE, just a way of assessing how good the RV function is. But the 2D imaging is what most people are familiar with. So instead of just one picture, we're sending multiple pulses along adjacent lines, and these pulses are reflected back to call or to give us a live image. Unfortunately, this picture is not moving, but basically that live image will show you how large the chambers are, how good contract, how is the RV contracting, and you can tell if there's any right atrial chamber dilatation. You can tell the function of different chambers, LV, RV, and also assess the size of different vascular structures. So that's most of the echo pictures that we acquire when we test patients for echo are actually 2D imaging. Finally, we use something called Doppler. So basically, Doppler is a way to detect the direction and velocity of moving blood cells, moving RBCs within the heart. So basically, you can tell whether the blood is moving one direction or the other. For example, in the case of tricuspid regurgitation, you can tell that the blood is leaking backward into the RA. And by Doppler method, you can also estimate how fast the blood is leaking backward. So if we know how fast the blood is leaking based on the Doppler method, we can estimate a pressure from speed by something called Bernoulli equation. I don't think today is the appropriate setting to explain all of this, but that's just the simplification of how we measure the pressure in the RV based on assessment of how fast the RBCs are moving during across the tricuspid valve. So if we apply the Doppler method, we can get the speed of the jet, and once we get the speed, we can change that into pressure based on the simplified Bernoulli equation, and that pressure is what we use in our reports to estimate the pulmonary pressure. So this is an example of a jet across the tricuspid valve, and you can see here we have something called CW, continuous wave Doppler, and we can see that the maximum speed of this jet is around 2.8. So the machine will do the mathematical conversion to us and give us a pressure of around 32. So what we can say from this is there is at least 32 millimeter of mercury of right ventricular systolic pressure. Of course, you have to add to that the IVC pressure to get the final estimated RVSP, assuming there is no pulmonary stenosis. So basically, that's the basics of echo. The recent guidelines have clear details of how should an echo report look like when we are assessing a patient for pulmonary hypertension. So it should look at multiple different views of the heart: long parasternal, four chamber, short axis, IVC, and they have clear explanation of what to look for and what are the normal reference numbers. Again, this is pulmonary valve flow, PW. We have something called, similar to LV ejection fraction, we have something called fractional area change. That's a little bit different in concept than the EF concept, but just a way of estimating how good the RV function is. We talked about this M mode, and we can estimate something called TAPSE based on that to, again, give us an idea about how good the RV function is. And we also look at the RA chamber, and this is probably one of the most important things, is the peak TR velocity, and finally presence or absence of pericardial effusion. So the echo report should be actually very comprehensive, looking at the right side of the heart and assessing different points that mentioned earlier to give you a better idea of how good the RV function is and how high the pulmonary pressure is estimated to be. So echo in general as a screening tool is considered very good tool. It is non-invasive, it is very reproducible, and it has high negative predictive value for the condition, and it's not very expensive, so it's considered to be cost effective. In summary, it estimates the right ventricular systolic pressure. It gives you an idea about the RV size and RV function. It can screen for additional congenital heart disease like an ASD, VSD, or something like that. It identifies possible causes of PH, such as left-sided problems. So if you have LV dysfunction or mitral or aortic valve problems, that can also be detected on echocardiogram. Next, we move to ECG, and in ECG, it's a very simple test, widely available. So we look at things like sinus tachycardia, we look at P pulmonale, we look at right axis deviation, like in this case, and we look at right bundle branch block or RVH, like what we see here, a tall R wave in V1, and some T wave changes in the anterior lead. So those are all findings suggestive of increased right-sided pressure. A chest X-ray is quite helpful, and it tells you that there is sometimes enlarged pulmonary trunk, bilateral. Sometimes that is confused with mediastinal lymphadenopathy. You can also see peripheral hypovascularity in cases of severe pulmonary hypertension. And if you happen to do a lateral X-ray, you will see that RV occupying the retrosternal shadow. Also the chest X-ray can be helpful in terms of looking at signs of left heart disease, pulmonary edema, and also signs of lung disease. So it should be part of the workup of patients with pulmonary hypertension. PFTs and arterial blood gases also quite helpful, and it helps you to distinguish between different pH groups and assesses comorbidities and the need for supplementary oxygen, and also if you're using or if you're looking at DLCO, for example, it can help you determine the disease severity. VQ scan is an integral part of the workup, and it is recommended to rule out the presence of chronic thromboembolic pulmonary hypertension. So we do that usually in the absence of parenchymal lung disease. And if you find a normal perfusion scan, CTIF can be excluded with a quite high negative predictive value. So it is a routine workup of any patients with increased RVSP on echo with no clear explanation. Usually that's accompanied with a CT chest. Usually we do it with contrast, and multiple points that we can get from the CT. We can get a quite clear assessment of how large the PA diameter is. We can also look for parenchymal lung disease, and if there is a contrast and a good radiologist, they can detect findings of CTIF on CT contrasts. The basic blood work includes CBC, looking for anemia particularly, kidney function, again, end-stage renal disease or chronic kidney disease can be a cause of pulmonary hypertension, liver parameters to rule out portopulmonary, hepatitis virus, and HIV serologies. BNP is considered an integral part of the testing because of its prognostic value. Iron status should be clearly documented because of subsequent treatment implications, and also basic screening of immunology like ANA, the double-stranded DNA is warranted to look for occult connective tissue diseases. Then if we have an echo that shows us a high, a good assessment of the RV and a clear number of RVSP, why should we still need a right heart cath? And the reason for that is that risk of inaccurate estimation of pulmonary pressure on echo is there because echo is not a direct measurement, but rather it is an estimation based on the tricuspid regurg signal, and that's not always available or very accurate. So you need the direct measurement with the right heart cath. Also, the echocardiogram doesn't really provide you with a very accurate estimation of PVR or cardiac output. It can be done, but it's not very accurate. And it doesn't tell you a precise measurement of filling pressures, which has a significant treatment implications. And finally, sometimes on echo, we cannot really assess how good the RV function is because of its peculiar geometry. So with right heart cath, we go with a special type of catheter, and we measure the pressure directly from multiple chambers of the heart. So from the right atrium, from the RV, and then from the pulmonary artery, and finally at the wedge position here with different waveform pertaining to each different heart chamber. So some technical consideration with the right heart cath is that sometimes if you have left bundle branch block and you're going with a catheter in the right side of the heart, you can induce right bundle injury and subsequently a complete heart block. So just be aware of that. Also, if there is a recent pacemaker, you shouldn't be very aggressive with manipulating the catheter. The tube should be short and tightly connected. And basically, there are very few contraindications. Endocarditis and mechanical valves are probably the main ones for as absolute contraindication. So this is a Swan-Ganz catheter, and you can see a short cross-sectional cut here. It has multiple ports, and each port serves a different purpose. Usually we do the right heart cath from the brachial vein, but the IJ can be utilized, and also the femoral veins can be used as well. It's very important to pay close attention to the leveling and zeroing of the pressures when we do right heart cath, because if not done properly, it can lead to readings that are not very accurate. This table shows you the basically the normal variables of different points of pressures measurement. So the normal reference for RA is between 2 and 6, and mean PA pressure, as you can see here, the normal number is between 8 and 20. So anything above 20 is considered to be pulmonary hypertension when there is also increase in PVR. So the upper cutoff limit of PVR is 2. So basically, mean PA of more than 20 and PVR more than 2 basically classify the patient as PH. And if they happen to have a wedge pressure less than 15, so that's pulmonary arterial hypertension. So this is just an example of RA tracing, shows you that the RA is about, the mean RA pressure here is around 10 or 11. This is RV tracing, shows you a very high right ventricular systolic pressure, about 94 or so. This is a PA tracing, and again, it shows very high PA pressure with a mean of 53 or 4. So that's clearly well above the cutoff of normal. And finally, this is a wedge pressure averaging around 14 or so, making the diagnosis pulmonary arterial hypertension, because this is basically less than 15 on average. So this is basically the summary of basics of right heart catheterization. It is very important to clearly estimate the left ventricular filling pressure, and this can be done by either pulmonary wedge pressure or LVEDP, or sometimes a direct LA pressure measurement, because left ventricular filling pressure is basically what's going to tell us if we should treat or not treat the patient. Sometimes we see patients who have all the risk factors for group 2 pulmonary hypertension, but when we do their wedge pressure, we found it low. We shouldn't always believe that, and we should challenge that pressure by giving additional fluid. And sometimes we're surprised to see the fluid challenge reveals the true filling pressure of the left ventricle. Finally, cardiac output assessment should be part of any right heart catheterization, and thermodilution and indirect FEC method should be used to assess the cardiac function. So this is basically the summary of all of the workup, or most of the workup that we do for pulmonary hypertension. And with that, I'd leave it to the next speaker, Dr. Shaya, to continue on this journey. Dr. Shaya is a consultant pulmonologist and pulmonary hypertension expert at King Fahd Medical Center.
Assalamu alaikum. Thank you, Dr. Abdullah. Thank you, Dr. Hassan, as well, for introduction, and also for the organizing committee for this webinar. So I'm going to speak about the pulmonary hypertension targeted therapy and algorithm of view. It's a bit comprehensive. I'll try to simplify things, so hopefully you will be with me. I will repeat a couple of slides from the previous, from Dr. Hussam and Dr. Abdullah as well, just to highlight the importance of this important thing. We can at least link it to my talk. So pulmonary hypertension is uncommon and limited awareness and limited delay of diagnosis or initiation of therapy can lead to potential clinical and worsening of the outcome, especially process of the disease and death. You can see the nice blood vessels in the left corner, good blood flow, smooth muscles, compared to the pillow one, which shows the increase in the thickness and proliferation of the blood vessels, and this will lead to limited the blood flow and consequently to the right ventricular dilatation and dysfunction as shown in the right side. So we can see the normal healthy arteries. There is normal and good balance between the enzymes and proteins, and this will lead to good normal blood flow compared to the other one when there is limited blood flow and proliferation of underlying smooth muscles. This will lead to cardiomegaly and consequencing of the signs and symptoms of pulmonary hypertension. There's 5 groups of pulmonary hypertension mentioned earlier. Group 1, pulmonary arterial hypertension. Group 2, left heart disease. Group 3, left lung disease related to pulmonary hypertension. Group 4, pulmonary hypertension related to pulmonary artery obstruction. And group 5, unclear or multifactorial mechanism causing pulmonary hypertension. Do we need to know exactly before starting the therapy which type and which group you are dealing with? The answer is yes, because each type of these things has different pathophysiology, and because if there is different pathophysiology, there is different treatment pathway. Group 1 is different from group 2, as well as 3 and 4 and 5. So you have to memorize all these things. You have to understand which group you are dealing with in order to treat your patient. So what is our goal in pulmonary hypertension? Targeted therapy. So to improve and restore the vasoconstriction and vasodilatation balance, also to improve the exercise capacity and delay the symptoms of progression of underlying pulmonary hypertension, decrease the clinical worsening and events in pulmonary hypertension, as well as we have to improve the patient quality of life. So in general, do we have a treatment for pulmonary hypertension, and what is the general measurement that we need to do in order to manage your pulmonary hypertension patients? The answer is yes. So we have to consider oxygen when needed, diuretics including furosemide and spironolactone. Anticoagulation is not anymore primary therapy. We have to add it in all pulmonary hypertension. So if needed, yeah, we can use it, especially in group 4 pulmonary hypertension, or if there is underlying causes for other possibilities other than pulmonary hypertension, like atrial fibrillation or so. Salt and water restriction is always important. Like we have to have like 1.8 liter a day of all total fluid intake. Supervised exercise rehabilitation is important. We are not limiting our patient to say don't do any exercise. Actually, we told them you have to work, you have to do some sort of exercise, and the supervision with some sort of specifications. Avoid pregnancy and contraceptions because pregnancy has carried a mortality risk in pulmonary hypertension patients. Lifestyle modification, and last thing is pulmonary arterial hypertension targeted therapy. I'm going to speak about it. It's not limited to treatment. We have to consider your patient at the center of your management in pulmonary hypertension. There is a medications, there is a palliative care, there is a social care, there is a health and cognitive and coaching of patient and life, rehabilitation, psychological support, and so on. In the previous era of pulmonary hypertension management, there's something called conventional pulmonary hypertension therapy, including calcium channel blocker, diuretics, oxygen, and digoxin, and so on. Those kind of medication or conventional therapy doesn't lead to improvement in patient pulmonary hypertension. Afterward, there is like a progression of an enhancing and management of pulmonary hypertension, including monotherapy or using double therapy or triple therapy, or using something called switch therapy that I'm going to talk about it later on, when we have one medication and we have to switch it to something else from the same family or different pathway. as well as sequential therapy, meaning we start one, add second one after specific indications, and then we have to add third one after specific criteria. The last thing that you have to consider in your mind is advanced therapy like septostomy and lung transplantation. So let's consider pulmonary hypertension is the main target of talk today, as pulmonary arterial hypertension, WHO group 1. So we have currently 3 pathways: endothelin pathway, nitric oxide pathway, as well as prostacyclin pathway. All these medication available all over the world. The endothelin, we have bosentan, ambrisentan, and macitentan. A nitric oxide pathway, including 2 families or 2 groups, which is sildenafil-tadalafil group and reosiguata group. I'm going to speak about it in short time. Prostacyclin include 2 types, either analogs like epoprostenol, treprostinil, and iloprost, or IP receptor agonists like selexipag. Since 1994, the initiation and approved the first therapy for pulmonary arterial hypertension, which epoprostenol, and after that, in 2013, we have a lot of medication come after. We have almost like 12 medication or 11 medication has been approved and had been tested in order to improve patient condition in pulmonary hypertension. A lot of study, a lot of medications, a lot of ideas in order to improve patient outcome. In the beginning, there is like similar to any other medication and pathways. You have to start one therapy and see how this will be improved with your patient outcome. They are looking to 6-minute walk test as the primary outcome. At the end, 2013, 14, and 15, and afterward, we are looking to the patient to the overall outcome, meaning we have to look to the patient if he's clinically getting worse or death, or we have to upgrade the therapy to prostacyclin and so on. So the idea of treating managing pulmonary hypertension has been shifted from time to another time. So in the beginning, there is 6-minute walk test. You can see in the blue, 6-minute walk test as a primary endpoint. In the red ones, looking to pulmonary hypertension outcome as a primary endpoint. 3 pathways: the prostacyclin pathway, using the endothelin arachidonic acid to enhance and increase the potency and production of prostacyclin. The prostacyclin attached to multiple receptors. The idea from prostacyclin to enhance and improve the cyclic A and B. Once we have more cyclic A and B in the body and in the blood, this will lead to vasodilatation and decrease the proliferation of the underlying diseases. The second pathway, endothelin. Endothelin is produced by the endothelin receptor, endothelin cells. So endothelin attached to endothelin A and B in the smooth muscles, and these will lead to vasoconstriction and vasoconstriction and proliferations. So by blocking the endothelin receptors, this will lead to the opposite favorable outcome, which is vasodilatation and decrease the proliferation. The third pathway is nitric oxide pathway. We have to increase the cyclic GMB by the nitric oxide. When we have the cyclic GMB in the body, this will lead to vasodilatation and decrease the proliferations. I'm going to speak in each one of them in details. Nitric oxide pathway. So we have sildenafil, tadalafil, and reosiguat. The sildenafil and tadalafil is increased. Let's start with nitric oxide is produced by endothelial cells. This will attach to soluble guanylate cyclase. By soluble guanylate cyclase, this will enhance the production of cyclic GMB, and this will lead to a favorable outcome, which is vasodilatation and decrease the proliferation of the smooth muscles. If we degrade the cyclic GMB, this will lead to cyclic this will lead to a GMB with no favorable outcome by phosphodiesterase 5. So by giving patients phosphodiesterase inhibitors, this will inhibit this enzyme, and this will increase the production and have more cyclic GMB and the favorable outcome or features. Soluble guanylate stimulator like reosiguat, this will enhance the work of soluble guanylate cyclase, and we will have more cyclic GMB. I'm going to speak about it now. So there is 2 types of work for soluble guanylate cyclase. The first one, when we have a reosiguat here, this will enhance the work of nitric oxide as well as the cyclic the soluble guanate cyclase by sensitizing the nitric oxide. When we have more stabilization and binding, this will lead to increase the generation of cyclic GMP and then the leading favorable outcome. If we don't have the nitric oxide in the body, or if we have limited nitric oxide, the cyclic GMP will work more if we give more riosiguat. So by riosiguat, this directly stimulates the cyclic guanylate cyclase independent to presence of nitric oxide. Sildenafil is a 20 milligram TID dose. It can comes with IV in some specifications. We can titrate it up to 80 milligram with some limited improvement if we titrate up. So 20 milligram TID is the dose for sildenafil. There is improvement in 6-minute walk test. Tadalafil is at a 40 milligram once daily. It comes with 20 milligram form. So we give 2 tablets a day for the patients. And there is improvement in 6-minute walk test, as well as if we continue using continuous 6-minute sildenafil after the first study, first 1 to the first 2, the 6-minute walk test continue to be improved. This group of patients has or treatment has specific side effects like headache, diarrhea, some back pain, dizziness, and nasopharyngitis is reported. Riosiguat has led to Nobel Prize in 1998 when it's discovered. We have a lot of compound. However, the only one has been approved in the clinical condition is riosiguat. Patent study 2013 improved 6-minute walk test has been achieved by 36 meters. Even if we switch riosiguat, switch of sildenafil or tadalafil to riosiguat, in patient naive, when we start sildenafil tadalafil after 3 months, we switch to riosiguat. There is improved in 6-minute walk test by 36 meters. The drawbacks of riosiguat is a step-up dose starting by 1 milligram to reach to 2.5 every 2 weeks. The limitation is a side effect, including hypotension. A lot of study has been shown and approved to treat pulmonary hypertension and phosphodiesterase inhibitors or nitric oxide pathway has been mentioned here. Endothelin receptor, as we mentioned, we have a bosentan, ambrisentan, and macitentan. So by blocking the receptor of endothelin receptor 1 and then receptor and P, this will lead to vasodilatation and decrease the proliferation of the smooth muscle cells. Bosentan is a dual endothelial receptor antagonist. The starting dose is 62.5 milligram twice a day, especially for patients with less than 40 kg or 12 years old, and we have to increase it after 1 month by 125 milligram BID. Breathe study, Breathe 1, resulting in increased 6-minute walk test and also improve the time to clinical worsening. As well as in early study, it caused improvement in pulmonary vascular resistance at 6 months by 22%. So what is the limiting factor or drawbacks of bosentan is the liver enzyme toxicity or increasing liver enzyme and liver toxicity. And as well as it is a teratogenic, so you cannot use it in pregnancy. Ambrisentan is a selective endothelin receptor A. It's a 5 and 10 milligram once daily. So instead of BID and bosentan, we can give once daily ambrisentan, improvement in 6-minute walk test. Again, it can cause liver toxicity, so you need to monitor the liver enzyme in patients with endothelin receptor antagonist, and as well as it is teratogenic, similar to bosentan. Macitentan is a dual endothelin receptor antagonist. It has one tablet, 10 milligram once daily. It's one of the backbone in treatment of pulmonary hypertension. The study is one of the landmark study in pulmonary hypertension. It has been the primary endpoint, is the first to event-driven study. So there's improvement in time with regard to primary endpoint, as well as a secondary endpoint, a 6-minute walk test and a WHO function class. Side effect for both bosentan and ambrisentan shows like increased respiratory tract infection, peripheral edema, nasopharyngitis, and headaches and anemia. Macitentan specifically can get like 1 to 2 grams of blood of hemoglobin can be dropped using macitentan. Again, it is teratogenic. However, it is less liver toxicity compared to bosentan and ambrisentan. Because of that, you don't need to do frequent liver enzyme monitoring like other medications. Prostacyclin, we have analogs like epoprostenol, treprostinil, and elioprost. It comes in different forms: IV, sub-Q, inhaled, and we have IP receptor called selexibag, comes in PO form. So having more prostaglandins, this will lead and attach to receptors of IB receptors in the smooth muscles. And by anhydrase cyclase, this will lead to increase the cyclic EMB when it starts transform from ATPs. So then we have vasodilatation and decrease the proliferations. It's a potent therapy. It can attach to multiple receptor. The prostacyclin analogs can attach to multiple receptors, specifically IPs. The IB receptor agonist as well can have the same outcomes. We have a lot of randomized control trials for prostacyclin. You can read it later on. You can take a picture from here, and you can see that it achieved the primary and secondary endpoints. Just a few words about each one of them. Epoprostenol can come in two different forms. The first one is thermosensitive, so it can affect it by the temperature, the room temperature. It is continuous IV infusion. It is 5 to 6 minute half-life. Because of that, it's continuous infusion. You need a big line, continuous using this machine. You have to give the patient this kind, it's called CAD machine, in order to deliver the medication 24/7. It has a significant burden of care. You have to care for all these kind of things, and you have to mix the patient has to know how to mix the medications at home. It started from 1 to 2 nanogram per kilogram per minute, and then we have to titrate it from time to time to reach 240 nanogram a day. Velitri, the other newer form from epoprostenol, it is more thermosensitive, so we can keep it in the room temperature for a longer period of time with similar characteristic of other epoprostenol. We cannot stop or abrupt using the epoprostenol because it can cause rebound or significant pulmonary hypertension if you stop the medication. So because of that, we have to make sure your patient is very aware and trained about using these medications, as well as can cause sepsis because of the big line presence. So one of the limiting factor of epoprostenol is a titration and side effect. The other medication analogs is from prostacyclin analogs is treprostinil. It comes in different forms: sub-Q, which is a well-known one, the IV form, and inhaled form. Compared to epoprostenol, it is 4 hours half-life, so it's longer half-life. It's a lighter burden of care if you use it at sub-Q. The only drawbacks here is the site pain, and we're going to show you one picture afterward, and site infection. It is longer half-life, as I mentioned earlier. You can see it is a small pump machine compared to the CAD machine, if you remember it earlier from the previous picture, attached to the tubes and to subcutaneous port. So you can deliver the medication 24/7 as well. And you need to titrate it from 1 nanogram to 40-60 nanogram per kilogram per minute. And this need like 1 or 2 months to reach to the higher dose and expected dose, similar to epoprostenol. As you see here, the site pain and infection is expected in these kind of medications. So you have to switch from area to another area to avoid these kind of things. And the site pain is a limiting factor. And sometimes we have to switch your patient from treprostinil sub-Q to IV. It is bioequivalent to sub-Q therapy, was almost similar to hemodynamic changes, and it's approved by FDA. It's not widely used, by the way, compared to sub-Q therapy. Elioprost is inhaled type of prostacyclins. It has 20 to 30 minute half-life, so it is something in between that epoprostenol and treprostinil. You need to use the inhaled machine, either the regular one that's used for like asthma patients, or you have to use the INIB machine, which delivers a specific dose for pulmonary hypertension patients. Because of the half-life is 30 minutes, so you have to give it 6 to 9 times with 2 hours to 3 hours interval between the doses, and this might be a limiting factor for this machine. It has been approved by AIR study, 6-minute walk test and NEHA function class has been improved. Tyvaso or treprostinil inhaled, it is 4 times a day compared to the other one. However, the problem is And this study has shows improvement in 6-minute walk test, but no significant improvement in clinical worsening or shortness of breath or NEHA function class. So it's not widely used for PAH. So in patient, when you need to start a patient with PAH, you have to make sure that your patient is very aware and has a good cognitive function and psychological ability to accept, to understand, and to manage. Because you train the patient, you need someone who is aware about the side effect and how to manage and how to titrate the medication. And you have to keep, you make sure that patient has a good hand and joint function, because you need to mix their medication at home and to have to put this medication in these pumps in order to deliver these medications. So it has as well a significant financial impact in your patient, as well as the center of using these kind of medications. The last form is oral therapy. Selexipag is starting dose is 200 microgram twice a day. We need to reach to 1,600 microgram twice a day. So because of that, we have to give the patient, or starting the patient because of side effect, 200 microgram twice a day, and increase the dose slightly every 1 to 2 weeks. And the limiting factor of increasing the dose is a side effect like headache, nausea, vomiting, GI upset, and diarrhea, and so on. Once the patient reaches to the tolerated dose, you have to stop there and keep the patient the same dose. So not all our patients reaching to 1,600 milligram BID because of the side effect. So this is one of the limiting factor. However, it has good favorable outcome compared to other eoprostanols and analogs. So prostacyclin analogs has more potent therapy compared to oral form. And the Griffin study, one of the landmark study for pulmonary arterial hypertension, shows Selexipag significant reduce the incidence of primary endpoint events compared to placebo by 40%. Side effect for most of prostacyclin therapy is the headaches, diarrhea, nausea, vomiting, jaw pain, and shortness of breath can happen for these patients. Let's go and do some quick review. This is from the AAC-ARS guidelines 2022. All the medication has been approved to treat pulmonary hypertension. The initiation dose and the full dose that you have to reach in your patient. And you can see here all these form and treatment. So now we understand all forms and management, and pathways and the families of pulmonary arterial hypertension targeted therapy. How we can use these medications. In the beginning, when you see the patient at time of diagnosis, you have to do something called risk stratification. Based on we have different calculators, and based on these calculators, you can understand how your patient is doing. Is he good? Is he really sick? By applying these kind of criteria. One of the known criteria is AAC-ARS guideline criteria or calculator. You have to understand, or you have to apply these kind of criteria to know whether your patient is at low risk of mortality, intermediate risk of mortality, or high risk of mortality, and apply these criteria like either clinical symptoms, 6-minute walk test, biomarkers, echocardiogram, 6-minute walk tests, whatever you have of these criteria, just apply it at time of diagnosis, and you can understand in which group or which pathway your patient is in order to start this kind of treatment. So once you diagnose your patient in pulmonary arterial hypertension group 1, you have to stratify your patient to understand in which group he is on. If he is a low-risk patient, intermediate risk of patient, so you can start them in dual oral and therapy like endothelin receptor antagonists and phosphodiesterase inhibitors. If your patient at time of diagnosis, he was on this group in the red group, meaning your patient has to be on dual oral therapy plus prostacyclin antagonist. After 3 to 6 months, it's recommended to see the patient again and re-stratify them. And the recent guideline, they simplify the criteria to four criteria, as well as to four stratifications. So a low risk, intermediate risk, intermediate low, and intermediate high, and high risk. So you apply these criteria in order to understand in which group your patient. after understanding your patient risk, then you can apply this pathway or algorithm. If he's at low risk, meaning you can continue the same medications. If the patient is at intermediate low, either you switch to reusagwat or add selexibag. And the patient intermediate high or high, you have to consider triple therapy or shifted or refer to transplant. So this is what we are doing in the pulmonary hypertension clinic. Stratify your patient, start therapy, re-stratify your patient, and adjust. So why you need to do this? Because if we improve your patient to low risk group, you have a better survival compared to patient if he's intermediate high or high risk group. Like in 5 years, survival is more than 90% in the low risk or improved to low risk, compared to 50 to 43% in patients with intermediate and high risk patients. And this has been approved by multiple studies, either by Swedish or Compera or other registries. Do we have new therapy? Yeah, there is a lot of medication in the pipelines in order to see how we can manage pulmonary hypertension. One of the important medications is called sotatercept, is activin receptor type likened to immunoglobulin G1. This to restore the balance and the pro and anti-proliferative pathway. So in order to improve the proliferation in pulmonary hypertension, restoration of this kind of enzymes will lead to the favorable outcome of improvement in patient overall outcome. And this has been approved to treat pulmonary hypertension. In the recent World Symposium in 2024, a few months ago, they have published that it has been approved and going to be added to the guidelines and to algorithm. We cannot release it right now because it's not yet released. The article is expected in August 2024 this year, and maybe in a few days, the newer guidelines or articles about the newer changes in the algorithm and treatment in pulmonary hypertension will be published. So sotatercept is part of these changes. It's considered right now the 4th pathway. Few slides, 3 slides about the pulmonary hypertension, just to complete the picture. Calcium channel blocker is not recommended to be started as a first-line therapy for pulmonary hypertension. We are not anymore using this kind of therapy since 1994. Unless you have a patient with calcium channel blocker responder or vasoreactive based on the right heart cath criteria. WHO group 2 left heart disease, we are not recommending pH targeted therapy anymore. There's all the treatment or all the literature and studies conducted to and try to manage pH in group 2 has been failed. Group 3, pulmonary hypertension with lung and hypoxia, no treatment recommended so far. There is one medication has been approved, has been tried in 2021 in an increased study called treprostinil inhaled, has been used, but I'm waiting the next guideline or articles from the World Symposium to tell us whether it is approved or not. The recent guideline doesn't make it higher in the class. So far, there is no recommendation in treating group 3. You need to treat underlying causes. WHO group 4, specifically CTF, we have 3 pathways of treatment. The first one is if the patient operable, go ahead and do the surgery, remove all these fibrotic materials. If the patient is non-operable, start medical therapy or pulmonary angioplasty, balloon angioplasty. If there is persistent or recurrence of a therapy after the surgery, you can go ahead with medical therapy or balloon pulmonary angioplasty. So the first line is surgery. The second line, the medical and catheter balloon pulmonary angioplasty. And thank you. So now I'm going to introduce Dr. Omar Tamimi. Dr. Omar Tamimi, he's a consultant cardiologist, pediatric cardiologist, he's an interventionist. Also, he's interested in congenital heart disease, pulmonary hypertension, a lot of work with pediatrics. So Dr. Omar will talk to us about some cases in pulmonary arterial hypertension. Dr. Omar, the floor is yours.
السلام عليكم ورحمة الله وبركاته. شكرا دكتور شايع، شكرا دكتور حسام and دكتور عبد الله. شكرا للمنظمين. Thank you all of you who's attending this seminar, and happy to be with you all in this lectures. I want to shift slightly the gears to something else, which is also part of the group one, which is BH, but it's a BH associated with congenital heart diseases. Still, this is a common diseases in our countries, and still we have adult patient and pediatric patient with congenital heart diseases who's not operated or operated and have a congenital heart disease with sequelae of this late presentation or other things. So this is case of a 40 years old man who's diagnosed in early childhood with congenital heart diseases. And that time he's not operated, but the thing was go with him is acceptably, and he get married with children. He was doing fine and reasonably. He's not working in hard work, but he's also in office work. But with time, he getting tired, so he can easily to get fatigue, and he presented to the ER with fatigability. He knows that he has a congenital heart diseases, so he came to seek medical advices. He has reasonable normal activity. He is having tachypnea on and off. He has no history of syncopes, and then also he has no loss of consciousness. So in other clinical symptoms, not having any issue, just he knows that he have cyanosis, and he has a clubbing. So his saturation that time was 85% in 6 liters of oxygen, and he has clubbing. He has no edema. He has a systemic murmur. He has loud second heart sound, and he is in class 223 of New York Heart Association. His ECG has biventricular hypertrophy with sinus rhythm. He's having polycythemia with hemoglobin of 19.5. So he's admitted to the hospital. The initial workup, chest X-ray, ECG, as I told you, chest X-ray has showing that he has prominent pulmonary vessels, and he has also prominent pulmonary arteries, as you see here. The heart size is in the reasonable size. The only thing which is really significant is the main pulmonary artery locus. So he went to the echo. Echo was done, and also the cardiac MRI. The echo reporting a complex congenital heart diseases. He has double outlet right ventricle with a good functions. Cardiac MRI, the same thing done, and he is showing the same finding of the congenital heart diseases with good function. Then the patient went for right heart cath, and the right heart cath, I will show you the result, also 6 minutes walk test, and also we check the BMB and troponin. That time his troponin is normal. His BMB is 400, which is higher than usual, and he can walk for 300 meters, which is lower than normal. So we are expecting in 6 minutes walk test in normal people is more than 500 meters. So he's in the 300 meter in 6 minutes walk test. So he underwent a right heart cath, and in the right heart cath, you can see that his superior vena cava saturation is low, 61. His pulmonary artery saturation is 85. It's almost the same of the aortic, and the pulmonary FAIR is normal. His pressure in the RA was 6, and in the pulmonary artery, the mean of 68. The same in the aorta was around 81, and the which pressure was 12. The calculated pulmonary vascular resistance index to his body mass surface area was 13.4. The systemic vascular resistance is 33, and the cardiac index is 2.3. This is the anatomy which I mentioned to you. There is a large ventricular septal defect. This is the normal heart. This is the right atrium, right ventricle, the pulmonary artery, left atrium, the left ventricle, the aorta, and they are separated by the ventricle septums. In this patient, there is a huge defect in the ventricle septums, and you can see that both the pulmonary artery and the aorta is coming mainly from the right ventricle. So the blood was mixing at the level of the ventricle and coming out from the both ventricle, and that's why he's cyanotic. So this is as mentioned in the classification and the guidelines, that he's in the guidelines in a congenital, in the group 1 pulmonary arterial hypertension. He's in the congenital heart group, which is 1-4. So it is associated with congenital heart diseases. So still, we are talking about what's same thing, which is Dr. Abdullah and Dr. Shaya and Dr. Hissam talk about it. So we are talking about the same subject. We are talking about the same things. So we are dealing with the same group of the diseases. So we are in the same boat. So regardless just what we are finding. So we are in group 1. So still we are dealing with the same diseases. We are still with the same complications and everything. So we should have all the pathway which is going with that. So when we move to this, the same definition, this is from the European guidelines for adult congenital heart diseases. So the same with the European. The European has they're accepting in 2020 the mean of more than 20 and which more than 15. The BFR is in the post capillary is 3. Less than 3, and in the pre-capillary, which is that can happen with other congenital heart diseases, is more than 3. The same definition, which is Dr. Hussam showed in 2022 guidelines for hypertension. The pre-capillary the same which is less than 15, mean than more than 20, and the BFR is more than 2 Wood units. So for our patient is fitting the pre-capillary is because the wedge is low. So because still in the congenital heart diseases, in the context of congenital heart disease, we can find the group 1, we can find the group 2, and we can find the group 4. So this is very important, group 5. So it's very important to know what you are dealing with, pre-capillary or post-capillary. If we are dealing with a pre-capillary, we are treating them as a group 1, and still we are using the same medication of the group 1. So the treatment is, because this is a patient have high BFR, the patient has started in Busantan. Busantan is one of the most used endothelial receptors medication in congenital heart diseases. Also the most common used medication, the congenital heart disease, than the other medication, the phosphodiesterase inhibitor and others. But Busantan was having a good study in the BREATHE-5, and that's why we are using it. We go to the same thing here. The most important interpretation of our guidelines, and still use this is in the pediatric and also in the adult. If you have a index pulmonary vascular resistant more than 8, so usually we are treating with him, and we are dealing with Eisenmenger cases. We do vaccination, and this is very important to have influenza vaccines and also the other protective vaccines. We do follow up in 6 weeks. In 6 weeks, he improved his New York Heart to 1 to 2. He started walking more distance, and BMB was coming down. In the guidelines from 2020 for adult congenital, if you can see, this is the Eisenmenger patient with the reduced exercise capacity, the 6 minutes walk distance less than 450, street treatment strategy with initial endothelial receptor antagonist immunotherapy should be considered, followed by the combination therapy. And this is 2A. And usually what happened before this is guidelines coming. Most of the time, we'll wait until the patient becomes very symptomatic and we start the treatment. And you know that the treatment was sometimes just starting one, and sometimes the people they just treating as a heart failure symptoms. But when the result of the breath study coming with this good improvement after using of Busantan, so that it's become in the guideline. So we need to be very careful in this setting of patients with the Zeminger syndrome. We should start them earlier. And as Dr. Abdullah mentioned, that we need to catch the patient early, start the medication early, improve the survival. And this is what happened also with the patient with congenital heart diseases. Our target of therapy is we needed the patient to have no heart failure and no ventricular failure, no more syncope, functional class of 1 to 2, 3. He should work more than 350, oxygen saturation more than 85. Transferrin saturation is good, so we should provide them with good iron supplement, near normal BMB, and with good TAPSEs. And also the index cardiac output is more than 2.5. To reach this better prognostic things, you have to have early start of treatment for this patient. You should screen them well. You should be careful not to miss anything with them. And you should not also blame only the congenital heart disease. Be careful if there is a congenital heart disease and associated pulmonary arterial hypertension. Should not wait more. You should refer them if you cannot start medication. Refer them with the centers. And as Dr. Hussam told you, we have adult congenital services. We have pulmonary hypertension services. So if you send your patient, he will get a good care in our clusters. And surely we are very happy to have all of you to see, to share with the treatment of your patient. So this is the end of my talk because we are late. So thank you very much. Dr. Hussam is back to
Dr.
you.
Omar, yeah, you were muted.
Yeah, sorry,
Yeah.
Dr. Hussam, it's your
Assalamu alaikum. Yeah, Dr. Omar. يعطيك العافية. Thank you so much for your presentation. Thanks for Abdullah and Shaya for their great presentations as well. We have some few questions through the talk. Some of them were answered directly. Some of them I would like to share on the group before we close our meeting. First question will go to Dr. Shaya. Are you Shaya with us?
موجود تفضل.
ممتاز. There's some questions we're talking about the process of referral. يعني احنا I think this is very essential to reiterate and explain the process of referral to KFMC, very well established center. So let's see how we can make things available to the community for them to utilize our services. Shaya, please.
Yeah, thank you so much, Dr. Hussam. Thank you for the audience. So this is very important questions because we have a big center for pulmonary hypertension. We establish all the 3 lines of pulmonary hypertension therapy. We have all the line of diagnostic workup for pulmonary hypertension. So we are, alhamdulillah, we are more than capable to deal with severe, advanced cases, different kind of PH therapy. So we are more than happy to accept all referrals from anywhere in the kingdom. First of all, if you are related to Ministry of Health or any healthcare institute in the kingdom, you can do a referral, do a report indicating that the general ideas like echocardiogram, sign and symptoms, something like that, plus the diagnosis, and refer to King Fahd Medical City for pulmonary hypertension or for pulmonary hypertension workup. And this will lead to cluster 2 Riyadh Health Cluster 2, and specifically King Fahd Medical City. Once it comes to us, we're gonna see the patient within 2 weeks, max 2 weeks to do all the work. So a system called Ihalati, just from your hospital, just refer to us. If you have any question as unclear for you, we are more than happy. Just text me, email me, Dr. Hussam, Dr. Omar, Dr. Abdullah. We can guide you how to do this. We can help you, and also if you have like a way to reach to us, we are going to guide you either to manage your patient in your institute or help you to transfer this patient to us as soon as possible, or do referral through إحالة system, and we're gonna get it. This is the most important thing that you need to know. It's a very simple report indicating pulmonary hypertension and through إحالة system.
Thank you, Shaya. Very nice. Any patient, including the private patient, you just need them to give them a medical report. If they are not going to go through the ihalati, if you are in the private and you don't know what to do, just give a medical report to the patient and tell them to come to the eligibility office at King Fahd Medical City. They come, they ask for certain basic information. In the near future, we'll be probably accommodating even more private patients, non-Saudis. So again, we'll try to help everybody as much as we can. The key is to mention in the report the word pulmonary hypertension. If that's the case, it will come to one of our clinics and the patient will be quickly sorted out and be seen within very short period of time. We have multiple clinics and we have very efficient system. Just in case that some referral practitioners or personnel, just write the word pulmonary hypertension. You can mention our names specifically in the referral, but the word pulmonary hypertension should direct the case to us, and we will be able to review it and accept the patient. Now, we as a service to you, available. You can always communicate directly with us. Yani as colleagues, as people who are, and alhamdulillah, we have enough experience. A lot of people, they know of us, and some of you probably guys have our numbers. You can get our numbers through your common, known people. Just communicate with us, and we will do all what we can to help you to get your patient in the right path.
Yeah, so just to maybe some updates. So we are recently accepting people who has insurance. So I received lately a couple of cases who has insurance to my clinic. So if they are even in private, non-Saudis, they are still eligible. If they have insurance, I don't know which type of insurance, but they are accepted. As mentioned, Dr. Hussam, if people don't know, just bring your report to the eligibility in King Fahd Medical City. Though they are not accepting the directly paper, but at least they can guide you how to do it. For the insurance people, they can go to the business center in King Fahd Medical City in the parking building, and they can at least guide you, guide your patient how to do these things. For physicians, just refer to us, contact us, we can help you. If you don't know, just give the patient the report indicating what's mentioned by Dr. Hussam. They can come to eligibility. At least they can guide them how to fit and apply their report.
Very good. There were some questions about the right heart cath, and the short answer is yes. Right heart cath is a must. We do it into all our patients, including the pediatric ones. Sometimes people might not comprehend that a small baby or a child, infant, they do have a right heart cath. So the right heart cath is the gold standard. If you're not sure, have the expert decide. Majority of the patients will end up getting a right heart cath unless they are really having some other disease that it does not need the right heart cath specifically for it. The last question will be related to the medications. There is a question about the expenses of the medication, specifically in the private ward. But let's talk in general about the cost of therapy and the availability of the resources, and how is the status in the kingdom in general. Shaya, do you want to take this one, or you want me to answer it?
I think you are better than me to answer.
No, but go ahead. No, I want you to answer it.
Okay. So for the cost of the patient, medications, for King Fahd Medical City, for the kingdom, all these medication is supportive and free of charge. So any patient is coming to us, Saudis, and they are eligible, they are free of charge. However, in the private, nowadays we have a good, let's say, to some extent, generic medications, and also the branded medications in the private. Previously, let's say a few months, few even years ago, we don't have much medications, and we have difficulty to have these things. However, in the private now, especially the big private hospitals, they have all the medication, all the lines. Let's say at least important 2 lines and pathways. Prostacyclin is not available in the private, but all other medications is available in the big hospitals in Riyadh. As too expensive, especially in private. For the governmental hospital is free of charge.
And even some patients who end up coming to the big institutions, even if they don't have good private insurance or they are not eligible, maximum that we can, whether giving them support through at least 1 year of care and therapy, or transforming their emergency file into like an exemption that they can be eligible to come to our clinics. So the idea is refer, truly refer. You don't know what will happen to the patient. We have different systems that we can work with to help the patient and, of course, get back with you. If you are interested at the personal, professional level with the disease, you please come forward, talk to us, talk to anybody from the pharmaceutical industry. Just let people know that you are interested, and I'm sure you're in the symposia, lectures, conferences, and even to build your personal experience. We get referrals from our colleagues who are subspecialists, and again, that getting back and forth between the experts is always healthy, and sharing knowledge and experience is always welcome. We do share experience in the region now. We are beyond the borders of Saudi Arabia. Our colleagues in the Gulf, they started seeing patients and establishing PH centers. Now we were pioneers. We did this many years ago, but now we are helping the other regional colleagues and centers to build their experience and share knowledge and help them to really provide the care that is much needed for these patients. There was a question that Dr. Abdullah, if he's with us, who would be better to see these patients, a cardiologist or a pulmonologist, in your opinion?
Yeah, to be honest, I don't think that's very relevant who sees those patients. I think as long as they are being seen by someone who knows what they're doing, regardless of their background, cardiology or pulmonology, I think that's what's important. And we're here for the patient. The most important thing is someone with the adequate training and adequate knowledge of how to treat such a complex condition, regardless of their background training.
Agreed. And like I said, we are unique. We need the help with a pediatric expert available. We need help with a cardiologist available. It's within one group. Pulmonologist the same, intensivist the same. So again, we share the knowledge among ourselves. Yes, everybody probably is capable of doing the work by themselves, but it's always nice to have a teamwork that can establish and accomplish the best outcome results. That's the question to Dr. Omar Al-Tamimi. People are still having a little confusion about the size of the problem in the pediatric age group. Very rarely people hear even about PH in kids. I know it's somewhat rare, but if you want to shed light a little bit on this aspect before we close the meeting, Dr. Omar.
Yeah, thank you, Dr. Hassam. Pediatrics have the same issue with congenital heart diseases, the pulmonary hypertension. Most of the common causes is the pulmonary hypertension because of congenital heart disease, then also the chronic lung diseases with bronchopulmonary dysplasia. Bronchopulmonary dysplasia in pediatrics, we're still using some of the pulmonary vasodilators with them, like sildenafil and iloprost nebulizer, and usually they improve. I think the difference in pediatric pulmonary arterial hypertension and the adult, some of them they improve. If they have a congenital heart disease, some of them they improve, some of them they progress like the adult. With the chronic lung diseases, they are better than adult because some of them they improve with their lung diseases and the pulmonary hypertension is improving. So they have a transient type of pulmonary arterial hypertension. You need to support them with the treatment until they improve or they progress like the adult. Yes, the issue with the pediatric is that with the transplant, lung transplant was not a good option for them, and they have major problem with the lung transplant, but still we are supporting them, and still we are receiving cases of pulmonary arterial hypertension. Thank you, Dr. Hassam.
Thank you so much, Dr. Omar. Thank you, Dr. Shaya. Thank you, Dr. Abdullah. Thank you, Dr. Omar. Thanks for Johnson & Johnson for sponsoring such an amazing activity. We're biased. This is our activity, but we really put this together with the help of Janssen to help the community to be more aware about pulmonary hypertension. Again, last word, we are here for you. Please do utilize us. come forward, send an email, call, send a referral. We will be seeing you, inshallah, again in another future activity in the refer system. Thank you so much. Thank you so much.